Hi, good evening. We are now presenting this webinar related to the main topics that we are working on the last period of time. My name is Gianluca Rovesti, and we are talking this evening about X-TPLO and RATO technique. So this is part of a series of webinars that will deal with the latest techniques that we are developing. And every week in different languages, we will present these topics. So just for the users online, if you experience problem, you can type on the right column the kind of problem that you are having. And during the lectures, you can type also if you have questions. And at the end of the lecture, I will answer to the questions that are present on the right column. Okay, so we have, of course, a little bit of advertising, just a little bit. I guarantee you, just 30 seconds. So we will have now 30 seconds of advertisement, and then we will be back with the first lecture that is about X-TPLO. Bye. Okay, so X-TPLO, we are talking a little bit about tips and tricks. Actually, there are not so many tricks, but let's say that we are talking about suggestions related to how to perform the techniques with avoiding the most frequent problems that we may encounter during the procedure. We will start very briefly with the biomechanical aspect of the stifle stabilization by means of TPLO. Of course, this is a half an hour lecture, and we will not enter every detail because you know that it's a very extensive topic, but we will try to address some specific points. The most important one to start with is the concept of tibial thrust. Tibial thrust is it shows the functional instability of the stifle during the stance phase, and it combines the joint anatomy with the periarticular forces. All the osteotomy techniques aim neutralizing it in a specific range of motion. The osteotomy techniques are referred as functional stabilization technique. That means the kind of stabilization they provide is not a static one. We are mainly interested in having the stifle stable during a specific range that is extension. can we show this kind of instability? Yes, of course, we can show it and look at it radiographically as well. So we can show a radiographic tibial thrust. You can see here a mediolateral projection of the stifle. I like the projection with the superposed condyles of the femur, but you can do it in a different, slightly different projections as well, meaning that not necessarily the femoral condyle should be perfectly superposed. The important thing, in my experience, is that it should be consistent. So we should be able to have a consistent projection in order to understand exactly what we are doing. And if we perform the tibial thrust while we have this mediolateral projection, we can look at this. We can look to the radiographic tibial thrust, that is cranial subluxation of the tibia compared to the femur. This kind of picture not only shows us what happens during the instability due to the rupture of the cranial cruciate, but also, in my experience, is very useful for the owners to understand what we are talking about. They understand very easily what's going on with this kind of picture. And this picture shows or explains also why we have this kind of relationship between the rupture of the cranial cruciate and potential damage to the caudal horns of the menisci, specifically to the medial meniscus. So this is the first approach, understanding the biomechanics of the stifle with the rupture of the cranial cruciate ligament. But a sentence that we should go deeper inside is this, that the concept of dynamic stabilization is where the cranial and caudal translation meet. What does it mean? It means that we don't have just a cranial tibial thrust that is controlled by the cranial cruciate ligament. We have also a caudal tibial thrust that is controlled by the caudal cruciate. Okay, so if we look to the change that the TPLO technique will determine on the stifle anatomy, we won't get into all the theoretical explanation of the neutralization of the tibial thrust, but just look to this change. And I can say, or my interpretation of this is related to the fact that the final position of the tibial plateau compared with the femoral condyles, that means the stifle range or degree of flexion or extension, is more flexed than the physiological position during weight bearing, during walking. This means, this is my interpretation, that even though the theoretical explanation of the stabilization is related to the angle of the tibial plateau to the long axis of the tibia, actually we are transferring with the pre-flexed position of the stifle, we are actually transferring the stabilization work, the stabilization duty to the caudal cruciate. Why? Because this flexed position of the stifle will change the control of the tibial thrust between the cranial and the caudal one. So TPLO mainly refers to and take advantage of this flexion in order to be able to stabilize the stifle with a cranial cruciate during the stance and walking phase. And this is the reason why during using TPLO as a stabilizing technique, we need, absolutely need an intact caudal cruciate ligament, because it changes the cranial tibial thrust into caudal. And of course, we need this anatomical structure that will stabilize after this change, that is the caudal cruciate. And this is the reason why in most of the publication and study, biomechanical studies about this topic, the suggestion is to avoid hypercorrection and to lay 5 to 10 degrees of tibial plateau angle. And this is to avoid simply to hyperload the caudal cruciate. So this is just a pill, just a little kind of piece of thought about the biomechanics of TPLO, but we should be aware of this in order to avoid hyperloading the caudal cruciate. Talking specifically about X-TPLO, let's say that the first point that we tried to evaluate was I hope that the hearing problem was worked out. I just asked for confirmation.
Esatto, ora si sente.
Okay, good. Thank you very much. Thank you. So the first point that we evaluated during the management of this project, that has quite a long story right now, was should we use the jig, the intraoperative guide that was suggested by Barclays Locum for performing the procedure. And all this issue is related to a concept that is a very important concept, that is the center of rotation of the joint. Based on the studies by Mike Kowaleski, and this I think is the most famous study that he published about the center of rotation of the study based on the Cora concept, we should assume that the center of rotation of the stifle is at the top of the tibial spines, the tibial eminences. And why is this important? Because if we look to the radiographic projection of the position of the tibial spines, we can easily understand that this is the center of rotation, but it's also the center of the joint. And this means that we cannot, absolutely cannot put a 3mm pin in the center of the joint, because we are disrupting this joint. So we need another point of insertion of this pin. So what I mean is, this is the proximal pin of the jig, and this is the jig, okay? So it is absolutely crazy to think about the option to insert this pin here in the center. So This implies that we must put the pin, if we want to use the jig, in a different location that is, of course, in solid bone into the tibia. But the problem is, when we perform the rotation, if we have our center of rotation that is in the center of the osteotomy, we will achieve a smooth, uneventful rotation. Instead, if we put the pin outside of the center of rotation, one will try to rotate the tibia after the osteotomy. We will have this kind of conflict because together with rotation, we will have also translation. So how did we manage for many years this kind of issue? Just releasing the jig. We were not able to rotate the tibia in a smooth way, so we released the jig, and the jig was not more able to counteract this rotation. But the question at this point is, how should we use the jig if we release it and if it's no more the center of rotation of the osteotomized tibia? So the final conclusion is that we shouldn't use the jig. And not only because these publications show that it's not really useful in order to achieve a more precise, a quicker procedure, a easier procedure, but also because the jig is cannot be, the proximal pin of the jig cannot be, for anatomical reasons, the center of rotation of the tibia after the osteotomy. So this is the starting point of this revision. After this, we all know, I think, the standard technique for tibial rotation. And this pin is inserted in a craniomedial to caudolateral direction, is inserted in the proximal part of the tibia in order to use it as a lever to rotate the fragment. Actually, we should pay attention how far the pin goes proud to the caudolateral direction of the tibia, because if it's too proud, during rotation, it can cause damage to soft tissues. We have the sciatic peroneal nerve there, the popliteal artery there, so we should be very cautious about that. But more than this, I was only a little bit disturbed by this kind of procedure because I thought that a very small pin will bend. A very big one can damage the bone. And sometimes I had the feeling that the bone was a little bit damaged. It was not very user-friendly as a maneuver. So we had this feeling that this was a little more or less the starting point for the revision of the technique that we made. If you use this standard technique for rotation, you should stabilize the rotation after you achieve it in order to avoid that it gets back to its original position. And this should be performed not as the original technique suggested by Slocum through the base with a wire, K-wire, through the base of the tibial crest, but instead through the distal insertion of the patellar tendon. Why? Because if we insert the K wire through the base of the tibial crest, we are at risk of creating a fissure that will fracture the tibial crest afterward. So this way, this K wire is inserted through the distal insertion of the patellar tendon. But at that point, since I didn't like this kind of technique, rotating by the use of this K-wire, we started thinking, should we use the plate for rotating? Is it not possible to think that a plate that is anchored to the proximal epiphysis of the tibia is strong enough to allow to use it as a lever to achieve rotation? And is this something really new? If we look to this book, that is the Brinker Pneumatic Flow, that is a book that I loved. This book played a major role in my professional education, and I'm very grateful to it. So this is a very old technique, and this a technique when we have a pelvic fracture with the acetabular component that is medialized, is pushed to the center of the pelvic canal. Instead of trying to grab it, performing very dangerous procedure for the sciatic nerve on its medial wall. Instead of doing that, we can put the plate on it, on the acetabular component, and use the plate as a lever to reduce the fracture. And I used it, and I used this technique, applied this technique many times, and I found it very useful. So my thought was, okay, if we use these very old plates, not locking ones, very old style plate, and they were able to assist us in reducing the pelvic fracture, why shouldn't you use a very strong plate with 3 locking screws in the proximal part to use it as a lever arm to rotate the proximal fragment? So nothing really new. The further point that we evaluated was how to get the measures for rotation. So the standard measure, we start with a table that converts angles into millimeter linear measure, and we try to use this measure during the surgery to convert degrees in millimeters and try to be as precise as possible in order to achieve the planned correction of the TPA. Of course, this is kind of tricky procedure because we change our scale, and with the X-TPLO, we don't need that because the measurement, the goniometer, is used during the procedure, so you can use this intraoperative guide. We applied this guide, this goniometer, to this underneath the head of this screw, and we can measure the angle where we are going to stabilize the plate, the proximal part of the tibia, in order to have the plate secured at a precise angle. What angle? We can look that in the middle of the plate we have a line. We should align this line to the desired degrees that we want to subtract to remove from the original TPA. That means if I have a 25 TPA, I want to get to 5 as a final position of the tibial plateau. I will select and I will align the line on the plate on the 20 degrees. Why? Because this amount of degrees is the amount that I'm going to subtract to the original TPA, okay? So this is the original idea and the peculiarities of the technique. About the instruments that we can use for using the technique, they are quite simple because a part of the plate has a proximal hole for temporary stabilization, a distal hole for temporary stabilization. It uses one cortical screw, and we will see during the surgical technique, and all locking screws. Our idea was not to start with the new screw system, proprietary screw system, but we started with compatible, Synthes compatible implants. So these implants are Synthes compatible. So if you have Synthes implants, you can use the plates without any problem, okay? And then this is just to avoid more implants, instruments, new techniques, etc. So just standard implants that we may have already present in our stock. So this is the intraoperative guide and reduction forces, and we will use how to use them during the surgery. So radiographic examination, we should start with that, with this locum position, and of course, this is the standard pre-op without the tibial thrust and with the tibial thrust and the sagittal projection as well. And this is related to the fact that we should be aware of potential deformities, torsional deformities, okay? Because they should be addressed during the surgery, specifically with patients with subluxation or patellar luxation. Okay, so the planning is always use a radiographic reference, a radiographic marker that should be a ball. Why? Because this is not dependent on how we rotate it to adjust for radiographic magnification to measure the TPA. I won't explain in detail every measure because they are very standard and well-known procedures, but the first line is to evaluate the TPA in a standard way as it was already described many times, and we should refer to the orthogonals to measure the TPA. Once we have the TPA, the angle of inclination of the tibial plateau, we should select the osteotomy. I don't start taking care of the exact radius of this circle. I just try to select the best osteotomy, I think. That means, for example, the criteria that I use should, we should stay far enough from the insertion, that is this whitish area, from the insertion of the patellar ligament. I want to have the tibial crest that will enlarge. It will be more wider immediately after the proximal part in order to have a tibial crest strong enough to resist the cyclic loading after the procedure. and I try to have the line of the osteotomy on the caudal cortex orthogonal to it. Once I have this ideal, let's say, osteotomy line that is drawn, I will adapt it to the available size of the blades. Meaning, if it's 22, of course, I don't have a 22 blade, I will use a 21 or 24 potentially. And if I have some doubt, of course, I will draw different circles in order to have different options to evaluate. Please be aware that using the intraoperative guide, the X-TPLO guide, we don't need to change the scale as with the tables related to the TPA angle and to the radius of the blade, meaning that whatever radius blade you use, the goniometer won't change. Degrees are degrees. So if you want to change 20 degrees, it doesn't change if you are going to use a 21 or 24 radius blade. Okay, so you don't need to change everything, every measure, if you decide to change your blade during the surgery. And then we will measure the distance from the center of the joint, and the center of the joint is is indicated by the insertion of the small insulin needle through the medial collateral ligament. The medial collateral ligament, if we insert the insulin needle through the medial collateral ligament inside the joint, we have a precise reference to the center of rotation of the joint, because this point will be superposed to the tibial spines here. And then we can take this measure that is actually the radius of the blade. And then the second measure is the same length, that is always the radius of the blade, and it's referred to the proximal part of the tibia. This is our second reference point. If we want to be more sure to understand where is this point, and sometimes this can be tricky because we have a lot of medial fibrosis on the joint, we can take the opposite measure from the tibial tuberosity to the line of the osteotomy. They are compensatory measures, complementary measures, meaning if I cannot understand exactly the first one, I can use the second one in order to orient my osteotomy during the procedure. So these are the 4 measures that we need to start with when we enter the OR. With these measures, we can have a kind of a precise guide to perform correctly the planned procedure. So now the X-TPLO surgical procedure step by step. So patient positioning, we are not taking a lot of time to do that, but I like dorsal recumbency with the contralateral limb supported and abducted, but supported. Why? Because I don't want to put the patient in an uncomfortable position. I don't want the dog will wake up with column pain, back pain, contralateral hip pain, etc. I want to have the patient very comfortable during the procedure. This, of course, is the scrubbing position. We will start then with preparing the surgical theater, medial approach, standard medial approach to the tibia, the group of muscles that we should recognize is that kind of group that are the tendons of gracilis, semitendinous, semimembranous muscle that were called by Slocum the Pesanserinus group. It doesn't exist as a term in veterinary medicine, but they were called like this. This is a human definition. The first structure that we should be always able to recognize is the medial collateral ligament. I hope you can see it here. Sometimes it's barely visible because of this fibrous structure, the medial buttress, that is fibrous tissue, that is very, very common in the patient with chronic disease of the stifle. Okay, so we should be able to recognize it, and we should be able to select the osteotomy position. So I have the insulin needle inserted through the medial collateral into the joint. This is my reference point. I will measure the distance from the center of the joint to the caudal cortex, that is the radius of the saw blade. The same measure on the tibia. If I'm doubtful about this one because of fibrosis, I can take the complementary measurement from the tibial tuberosity to this point, but at this point, I have these 2 points that are my reference for the osteotomy. If we have a specific radius of the circle, there is just one and only one circle that has the same center and pass through 2 points. So we cannot have another circle that has the same position. Okay, so we are very secure that this is the position of our osteotomy. So I have the insulin insulin needle inserted into the joint. I will take the first measure distance from the center to the caudal cortex, and the second one distance from the center to the top of the tibia, always again the radius of the saw blade. Okay, now I will hold the limb in vertical position because I'm inserting a few 8-10 millimeter below the joint level that is marked by the insulin needle. I will insert a 1 millimeter KY. Why 1 millimeter? Because I can change it, and I can bend it very easily, okay, without inserting it again. So I will have it on its correct axis on both planes, vertical and horizontal plane, because this will be my guide during the osteotomy phase. So I will align the saw blade to this KY. And this is very important because sometimes we keep to tend to hold this blade in an angle. And I had some cases where my cases ended up in this way. So with the oblique cut, this is not good. This will hinder also the rotation phase. So I want to stay on the frontal plane, and this will be my guide. The specific X-TPLO technique, once the osteotomy is performed, and I can guarantee you that it won't move. It won't. So we don't need the jig to stabilize it, okay? So the osteotomy is performed. I can look at it and I will establish more or less its half, and I will put the plate with the screw number 2, that is this lower screw, lower hole in the plate, in the middle of the plate, immediately caudal to the half of the osteotomy line, okay? When I'm satisfied of its position, and I will check that the screw number 3, that this one, will be underneath the axis of loading of the stifle, I will stabilize the plate by a 1.5 K wire, like this. At this point, I don't need a precise angle of rotation of this plate, just more or less, okay? But I want to check that the plate will fit correctly in this position, and this K wire will stabilize the plate in this position, and I can check exactly if I'm happy of this location of the plate. Of course, for further details, you should attend the course, because of course we have just a few minutes here, and the course will take all the day long, okay? So this is the reason why I'm running a little bit, but we have some specific tips in order to understand if you are positioning correct the plate. And at this point, I can insert the first screw, number 2. I won't tighten completely the screw number 2, and I will hook the guide underneath the head of the screw, like this. So the guide will be hooked underneath the screw, and I can stabilize the guide. This arm of the guide is aligned to the long axis of the tibia, okay? So this arm is aligned to the long axis of the tibia. When I'm happy of this, I can stabilize the guide with a 1 millimeter K wire into this slot in the caudal part of the guide, okay? And now I can align this line at the center that is laser marked in the middle of the plate to the angle that I want to subtract from the original TPA. So again, if I have a 25 TPA, I want to get 5 as a final situation after the procedure. I will put this line of the plate on the 20 degrees, okay? Because I'm subtracting this amount of angles. Okay, now I will rotate that the plate is in the new position. I will insert again this K wire so we can stabilize the plate in this new position. And once I have the plate stabilized, I can, like this. So I have the guide hooked underneath the head of the screw number 2. The guide that is positioned, the plate that is aligned to the amount of degrees that I want to subtract from the TPA, and the K wire here in the proximal part that was first inserted to look for this position, removed to rotate, to be able to rotate the plate to the correct amount of degrees, and then inserted again in order to stabilize the plate. And now we can start stabilizing the plate. It's very important to thread the guide into the plate, not just to lock it. Why? Because the direction of the screws, it's mandatory, it's very important in order not to penetrate the joint. So sometimes you can have the feeling that is counter-sensitive, it is apparently something that you say, okay, how it's this screw so angled? Okay, don't worry. If the guide is threaded into the plate is the correct direction. So we'll insert the second screw, number 1, and then once we have this position, we can remove the guide K-wire, because we have 2 points now, tighten all the 3 proximal screws. So now the plate is anchored to the proximal part of the tibia without any anchoring to the distal part, okay? Using this reduction forceps, sometimes it's enough to rotate it by hand, okay? We have also an handle that can be screwed into the plate, but very often we can rotate it by hand. We can bring the plate in its final position aligned to the long axis of the tibia. Of course, we need a reference for that. And our reference, this is the tip of the reduction forceps. We can use right or left. But our reference is, again, inserting the K-wire that was used previously into the guide as a mark, as a reference, an anatomical stop. Why? Because we should bring the plate in contact with this K-wire, because this K-wire is our zero reference. When we are happy of the final position of the plate, we can apply radial compression by a forceps. We are not going into the details simply because we don't have time enough for that, but we should apply radial compression in order to compress the 2 segments of the tibia on the radial surface of the osteotomy, and insert this 1.5 K-wire in the distal hole in the tibia. In this position, the plate is aligned correctly, and if we measured correctly, we should have also achieved the rotation needed to reduce the TPA to the scheduled amount of degrees. It is important that this K-wire will hold the plate very flat on the tibia. Why? Because now we should insert this screw that is a compression screw in this compression hole, DCP style compression hole. And it's very important that this screw will be inserted parallel to this K-wire. Why? Because if the screw has an angle, while we are tightening it, it will rotate the plate. And if it will rotate the plate, of course, it will rotate the proximal part of the tibia as well. So this K-wire should hold the plate very flat on the tibia, on the distal side of the tibia, and this screw should be parallel to the direction of this K-wire, okay? Of course, once we achieve this compression, the insertion of the 2 locking screws in the distal part of the plate is just routine. Why? Because they are the easiest screw. The plate is stable, the tibia is stable, and it's just a standard routine procedure for locking screw positioning. Of course, we should perform comparison between before and after to check for correction. And please be aware that no one of the distal screws should pass through the codomedial angle of the tibia. Why? Because the codomedial corner of the tibia is a very delicate and mandatory anatomical structure in order to avoid any tibial fracture. If we have a screw that fissures the codomedial corner of the tibia, this one, we may have troubles. So we should be aware that the caudal border of the plate is aligned with the codomedial corner of the tibia, but no screw should pass through it at an angle, because this will be very risky for having tibial fractures. And of course, we should be able to check that the plane of the osteotomy is on the frontal plane, no inclination, no joint penetration. Okay? I apologize for the run that we had during this lecture. And of course, if you are interested in future courses about this technique, you can check on this link on this website, and you can find the closest course about the technique that fits with your organization. Furthermore, if you have questions, I'm available to answer questions not only after this webinar, but every time. So you can use this email address to ask technical questions. Okay, it was a little bit of a run. Now we have other 30 seconds of advertisement, but we will be back in 30 seconds. Thank you very much. Okay, so sorry, I have to change. Okay. Now, we are dealing with a technique that is the biggest effort we perform in the last period, couple of years, a little bit more actually. That is RATO. RATO, you know, means Rovesti abduction trochanteric osteotomy. And I am aware that giving a technique your own name can sound conceited. For me, it simply means taking responsibility for what I'm showing you today, okay? because the technique, we cannot consider the technique already mature, already ready for standardized and let's say public use. But I want to share with you some concept and of course some clinical result. So what is the problem that we try to address? The problem was the treatment of young dogs with only hip laxity without joint remodeling and clinical symptoms. And of course, we had other options. We will get back to this argument after a while. But for example, in some cases, I was very afraid to think that in a very young dog without any symptom to perform a DPO or TPO, I was a little bit afraid. And also because we all know that this kind of techniques has a high, not high risk, but the risk is to have severe complication. That's a different concept, okay? So the approach was, do we have another option to treat this kind of patient? Because we know that with this kind of laxity, they will develop DJD, degenerative joint disease. So we know that this will happen, but without the aggressiveness and without the risks related to other procedures, okay? So, of course, we should start with a predictable evaluation, radiographic evaluation of hips. Very briefly, because this is not a complete course on that, but just to introduce some concept, some kind of stimuli, okay? Some food for thoughts. So extended hips, I think that we all know the technique for extended hips, and the kind of picture that we want to get is this kind of picture. Then we need frog projection. Frog projection is the projection that will show us if the femoral head is capable to get back into the acetabulum. This is not enough. This position is not enough to leave the dog free to position, because this will usually don't show what I want to see. So this is not the good one. I want this kind of positioning. We should push on the tarsi in order to have the stifles closer to the abdomen, in order, this is the position, in order to get this kind of projection. How I recognize that this is I want to have? The trochanter should be caudal to the hip, and the femur should be oriented cranially, okay? They shouldn't be orthogonal to the pelvis, okay? And the trochanter shouldn't be superposed to the femur. DAR projection is mandatory projection, dorsal acetabular rim projection. So this is the position. The dog is a sternal recumbency, and we should be able to hold it as symmetrical as we can. Of course, to have the radiographic head that can incline is a big advantage, because we orient this angle in order to achieve the kind of projection that we want to. But the important thing is that we should be able to see the dorsal acetabular rim and the distance between the ventral border of ischiae and the dorsal border of the acetabulum should be between 3 and 7 millimeters. So the ischiae and should be here, dorsal here, the ischium, and sorry, and the dorsal acetabular border of the acetabular is here. Okay, this is very important. Why? Because as you can see, I can appreciate the shape of the dorsal acetabular rim. I usually like to perform a little bit of distraction that is not the standard distraction, but is the specific distraction, simply to appreciate if we have more laxity than the one that I see from the extended projection, okay? And this is performed quite simply because this is performed simply putting this kind of destructor between the ties and performing this simple compression test and taking this projection. What we can see, usually there is not a major difference. The first projection that we see is without distraction, the second is with distraction. As you can see, usually the difference is not a huge one. Okay, so the mandatory X-ray pictures for pre-op evaluation that we should have in order to evaluate the case are extended hips, and of course here you can evaluate if the hip is lax or no doubt, I think in this case. Then frog position, I should be able to understand if the hip, the head of the femur will get back to its position into the acetabulum and dorsal acetabular rim DAR projection. Then, very important, mandatory Ortolani test. We have two positions to perform Ortolani test. On the side, why I think that this position is important to learn. Because during the procedure, during the surgery, we are testing the effectiveness of the procedure with this position, not with the dorsal one. So it is important to learn to apply this procedure test during the surgery by performing it in a standard way, okay? Or in a dorsal recumbency. That's my standard procedure during X-ray examination. How Ortolani test works? In a standard stable hip, just abducting and pushing on the stifle will make the hip to rotate in its physiological position. But if we have subluxation, when you are pushing, we will have this kind of subluxation and we will get abducting. We will have this click getting back to its original position. And this is the reduction angle. Reduction angle. If we get back to the vertical or horizontal position, we can feel the subluxation happen again. And this is the subluxation angle. And these two angles are mandatory for our evaluation of the case. This is how I perform this test during standard procedure. This is not a fancy goniometer, just one limb of the goniometer is vertical. The other one is laying on the medial surface of the thigh, and I can read the angle here. So I feel the reduction angle, I will measure reduction, okay? I feel the adduction subluxation, and there I measure the subluxation angle. Very straightforward. The important thing is to interpret the Ortolani test. The reduction angle is a crude index of the joint laxity. The higher, the more lax. Of course, not in a linear way. We cannot say it's 20 degrees, we have a 20 laxity, 30 degrees, 30 laxity. It's not like that, but it's a crude index. The higher, the more lax. The subluxation angle is a crude index of the status of the dorsal acetabular rim. The higher the subluxation angle, the more open the angle of the dorsal acetabular rim, okay? So not linear, but very important in order to understand what we are dealing with. The negative ortolani test, everything is always good? Of course, no. We should put together radiographic evaluation and ortolani test. So this is very important to understand. They are complementary evaluations, okay? With interpretation of ortolani test, good or bad, if we have a 30 degrees reduction angle and 10 degrees subluxation angle, we have a high laxity, but a good enough status of the dorsal border of the acetabular, and it can be managed like this, okay? If you have a 40 degrees reduction angle and 20 degrees subluxation, we have a huge laxity, but also a dorsal rim that is highly remodeled, is open, very much open. So this is a bad case for this technique. With a 22 reduction, 10 subluxation, I think that the laxity is high, but not huge, and the dorsal border is not very remodeled. So this is a good case for this technique. And what about if we have 10 degrees of reduction and -5? So we have to go to the negative side of the adduction to achieve the subluxation. This is not a standard position for dog during walking or stance phase, etc. So if you have a transitional angle, an angle that passes through zero, let's say, this means that this dog has no need for surgery. Why it doesn't need any surgery? Simply because during the physiological working, this femoral head won't subluxate. So no need for surgery. We can evaluate other supportive, conservative procedure, but not a good candidate for surgery, or let's say not a candidate that needs for sure surgical treatment, okay? So the potential treatment that we have in this case of patients can be, of course, DPO or TPO. We are not going to go deeper into each technique, but simply to mention them. Of course, it is possible, but the benefit should be balanced versus complications that can be very heavy complication, very severe complication, and aggressiveness of the procedure. And the procedure, of course, is very aggressive. And arthroplasty, dorsal acetabular rim plasty, that I still perform after many years, that when I was taught about it by Barclay's Locum. When we have this kind of situation, very severe increase of room laxity, we have here a very high room between the femoral head and the acetabulum. This means that these femoral heads are not entering, are not sitting anymore into the acetabulum, but most importantly, look to these borders of the acetabuli. So if you look to these dorsal acetabular rims here and here, you can see that they are completely disrupted, and you can also see the femoral heads where they are. They are not sitting inside the acetabulum, but they are more or less sitting on the border of the acetabulum. So this is the kind of acetabulum that is called pagoda roof style. Pagoda roof border means open, okay? It's open. And this is not a good candidate, neither for DPO, TPO, nor for RATO technique, okay? So we can see how it works. The dartroplasty, this is the border, this is a CT, of course, and this how the border, the new border looks like after bone consolidation, but we are not going to enter this kind of technique. So the objective of RATO is to preserve the joint by a surgical technique as minimally invasive as possible. And of course, it must be effective, because otherwise it doesn't make any sense. What is the background that we have? The background was the publication by Barclay's Locum about the femoral neck lengthening procedure. This is the technique. Of course, this, to me, is a very scary osteotomy technique. We have an example that was published by a colleague, an Italian colleague and friend, Massimo Petazzoni, that published this case. And if you follow how the osteotomy was performed and follow the progression of healing, of course the patient healed, but you can realize that let's say the kind of osteotomy that I wouldn't perform and afterward going home very, very calm, okay? I would be a little bit scary of this kind of osteotomy. And actually, I'm quite convinced that this femur actually fractured, and this is the reason why the femur eventually was in varus. But this is not the point. The point is, I think this is a very dangerous, potentially dangerous procedure, and very aggressive, of course. So we should compensate about that. Okay, so I needed something different. Lengthening, but consistent, predictable, safe for the patient. This is what I wanted. So the criteria for inclusion of RATO: an increased joint space, ortholani positive, but we should understand, because if it's a transitional angle, it won't need this kind of situation. As if it's too higher, I'm not applying the technique, okay? A good dorsal acetabular rim and an acetabular filling less than 2 millimeters, okay? So this kind of situation with good borders. And in order to evaluate the filling, I will evaluate the acetabular part, the head, femoral head part, and I will evaluate this measure, this distance, in order to understand if there is good indication for this procedure. Okay, when I have this kind of situation, this patient, I can see, okay, there is a lot of laxity. We can see that the acetabular filling is quite high, but most importantly, in this patient, look to the left hip. The border, dorsal border of the acetabulum is completely remodeled, and we have a huge filling here. A little bit better on the right side, but nevertheless, the dorsal acetabular border is remodeled already. So not good candidate, not good candidate. If one or more criteria are not met, exclude from RATO. And if the criteria for inclusion are met, of course, proceed with the technical sequence. So this is the technical sequence: pre-op X-ray evaluation, ortolani test, surgical procedure, post-op X-ray evaluation, and ortolani test post-op. So the pre-op evaluation and planning, the amount of abduction, how much we should abduct this trochanter. We can use this technique that is measuring the circle within the acetabulum, the circle of the femoral head, and measuring the distance between the two centers. And the amount of abduction should be at least this distance, okay? If let's say that this is 9 millimeter, how big we should perform the osteotomy, because there is a relationship between the abduction and the length of the osteotomy. We have a table for each measure. We can see that for the 9 millimeter abduction, we need at least 45 millimeter osteotomy. And this is why we should take the reference of the table and put the drawings on the X-ray. So this is the 45 millimeter, and we should take 1/3 lateral and 2/3 medial on the area of the trochanter area, okay? So this is why, because I want to have this medial part very strong one. I don't want to take the risk to have a femoral fracture. This is the objective. And we should be able to insert the wedge inside this osteotomy. Okay. So the instruments that we are going to use are very simple because distractors, very straightforward. The wedges, they are porous titanium wedges. They have this arrow on the roof, and this arrow is directed to the cranial direction, okay, due to the shape of the femoral metaphysis in that area. And then we developed also a plate, even though the cases that were used to develop the technique uses only K-wire and tension band. Why? Because I wanted to have a specific reference that was just technical, not a reference related to other potential issues, to the plate, to the shape of the plate, to the modeling of the plate, etc. So the plate is useful just for one reason. What is the tricky part of the procedure with a tension band? Inserting a big circlage in a sagittal hole in the diaphysis of the femur, okay? This is quite tricky. So the plate is handy simply because inserting a couple of cortical screws on the lateral diaphysis is very handy and quick. This is the only reason why. Okay, so surgical procedure. I always start with the tenotomy of the pectineus muscles. we are not going to enter for time reason into all the anatomy, but the pectineus muscle will insert with its tendon of the pectineal eminence of the pubis here. And we are going to cut it here on the pubis, okay? So the procedure is quite straightforward. We can easily see the muscle. And if we go deep into the pectineal eminence and just cut the tendon, it won't bleed. So it's a bloodless procedure. Straightforward, but of course you should practice for that specific anatomy. But the tenotomy is a kind of straightforward. You can see the tendon that is severed here, and once it is completely severed, the muscle will slip upward, and the assistant will feel that the abduction of the limb is much easier, okay? Then we will perform the lateral approach to the hip. So we have the vastus lateralis muscle here, and we should cut it, we should incise it, because we have to free all the cranial lateral part of the proximal femur. We can perform the osteotomy by an oscillating saw, of course, and in order to proceed, we should be aware what is the sagittal plane of the femur. Not always easy. So we should hold the limb like for femoral head and neck excision in order to appreciate the sagittal plane of the femur. And once we feel confident that we can have the correct plane, we can select the plane and mark the plane by inserting 2 K-wires, one at the proximal extremity of the femur on the trochanter, on the ridge that is on the proximal part of the trochanter, and one on the femur very close to the lateral cortex of the femur. Even though it is completely possible to perform the osteotomy by the oscillating saw, my experience is that if you are not very familiar with this area and with the angle of the blade of the oscillating saw, this can be dangerous. And the reason why it can be dangerous is because if we mistakenly perform an osteotomy with an angle that is too open, we can cut through the femur, exiting much more caudally and medially than expecting. Caudomedially, okay? And this can be dangerous because the part of the femur that can be osteotomized can be much bigger than planned. So we should be aware of this, and this is the reason why we developed an alternative way to perform in a more predictable way this osteotomy. So this is the wedge, titanium, porous titanium wedge, and we can insert the wedge underneath the lateral trochanter part that was previously osteotomized. And then, as a standard technique, because this is still my standard technique, once it is inserted, we can stabilize it by 2 K-wires, 1.5 K-wires that pass through the trochanter, the wedge, and the metaphyseal part of the femur. And they will stabilize this construct represented by the abducted trochanter, the wedge, and the metaphyseal part of the femur, and then I will use a circlage wire, a big one, 1.2, 1.5, in tension band construct. The problem here is that we have a lot of muscles. So inserting a big circular wire in a sagittal hole in the femur can be very tedious and very time consuming. And this is exactly the reason why the plate was developed, in order to make this procedure easier. But to be able to perform the osteotomy in a more predictable way, we developed this technique by the Gigli. Gigli was a surgeon, Italian. In Italian is Gigli, not Gigli, but let's say we are talking in English. And it was not an orthopedic surgeon. It was a gynecologic surgeon. And Gigli was developed to cut the pubis during parturition, difficult parturition, okay? So nothing to see with our objective. This is how Gigli was presented and used for. Okay, so the major issue using the Gigli free is the line of osteotomy. If you apply the Gigli you can cut, of course, the trochanter, but in this way, it's too short because we are pulling on it, okay? So we should be able to direct the direction of the cutting. And 6 months and many attempts later, I saw the light. I can guarantee you that this was very frustrating, time-consuming, and the kind of situation that you see, okay, I want work this problem out. I felt so badly, okay, during this period, but eventually I applied all my stick-to-itiveness to this. I was very determined and I saw the light. How? So we know the distance that we should perform the cut in order to achieve the abduction that we need. And at that distance, we will insert a K-wire as close to the cortex of the lateral cortex, of course, of the femur as possible. And once we insert the Gigli underneath the group of a tunnel, let's say, underneath the gluteal muscles, like this, we can pass the wire of the saw underneath the K-wire and use this K-wire as a guide to direct the osteotomy line, okay? I will show with some quick movies, not too long, because as anticipated, we had not a lot of time this evening, but I think that can be of general interest. So I inserted the K-wire. I will perform a tunnelization underneath the gluteal muscles, and I will get the wire of the Gigli underneath the gluteal muscles in order to have it correctly positioned in the trochanteric fossa. That is mandatory to check that it's in its position, the correct position. Once I'm sure that we are in the correct position, I will start cutting with the Gigli passing it underneath the K-wire. And this will direct the wire of the saw to the position of the K-wire. And this is very beautiful technique because the kind of cut that we can perform, this is a fluoroscopic picture during the procedure. So we can position the K-wire in the jiggly wire in a trochanteric fossa and start performing the cut, passing it underneath the K-wire here. Okay. And while we cut, you can see how the cut will progress to the point where the K-wire is. So this is, in my experience, a beautiful way to achieve exactly the kind of osteotomy that we planned to. At that point, of course, we can ending the osteotomy and applying the K-wires, of course, K-wires mandatory through the trochanter, through the wedge. There are specific technique to pass through the wedge, but this is not a course. We don't have time for each single detail, but through the wedge, to the trochanter, through the wedge, through the metaphyseal area of the femur, like this. So the plate is made to accept this kind of K-wires here, and eventually, of course, stabilizing the plate by means of standard cortical screw that is much easier and quicker than passing the circular wire through a sagittal hole in the femur. The post-op evaluation is like this. So we should perform the same, more or less the same procedure. I don't perform in the post-op the dart projection simply because it's a little bit stressing for the hip. So I perform the lateral projection. But Ortolani test must be negative, okay? If I perform the Ortolani test during the procedure and it's not on the lateral side, as mentioned before, and it's not negative, I will correct the procedure. I want the dog to exit the OR with a negative Ortolani test. Okay, PO management, we don't have a lot of time, but the important point is no bandages, just adhesive tape on the wound. And the follow-up, 10 days recheck, like this. It's okay, still negative, Ortolani. At 45, 60 days, depending on the progression on the first one, recheck, and if it's fine, second procedure. So if it's fine, I will check the first one that is still very good and is still well inserted, and if the second hip is still in good condition, I will perform also the second one, same session, okay, like this. And then, of course, follow up. The procedure is usually very well tolerated. This is 3 days post-op, the second procedure. So adhesive tape, but no bandages, because we want the dog to use the limb, okay? And of course, very important, 6-month follow-up. So in the follow-up, you can see that here the callus is already developed for both of them. The congruity of the hips is very nice, and the acetabular borders are still good, and this is preserved by the fact that the hip function in a physiological way, let's say, okay? So the future developments: collect and evaluate the long-term results, develop and standardize the surgical steps, and publish the results. And for everybody that can be interested in be part of the project, I think we are very happy to accept. If you are interested in a course, you can check for the next courses on this page, events at mayora.eu. And if you have questions about the technique, I'm available to answer your questions, technical questions, of course. This is my email address. I'm apologize for running a little bit, but as you understand, we had a very short time for the complexity of the topics that we delivered this evening. So we were a little bit running in order to give you as much inputs as I could. Okay, so we have the last very short advertisement, and then I will be back for your questions if there are from the audience. Okay, I hope that everybody can see and hear me. I see that we have still a little bit of attendance here. So if you have any question about what I presented this evening, please go ahead and type your question on the right column that you see on your screen. Don't be shy. No problem for asking. Or, of course, you can also use my email address in order to ask by email, but as you prefer. Just wait a few seconds to check if anybody asks. Okay, fine. Please be aware that we will make the same webinar next week, but in Spanish. And in 2 weeks, we will talk about X-porous TTA technique. I don't have my preferred technique. I try to select the technique that I think may be preferred by the patient. So I use TPLO, TTA, extracapsular, whatever, okay? Okay, there is a question. I saw you use some topics. I don't know what is topics, but standard measure on picture was only on cadaver sometimes. No, it was during surgery actually. What I showed you was the preparation on cadaver, but after we were more familiar, okay, measuring caliper. Okay, yes. So there is a relationship between the amount of abduction that you can achieve and the length of the osteotomy. The table has the meaning of telling you what is this relationship. If you want to abduct 5 millimeter, the length of osteotomy is shorter. If you want to abduct 12 millimeter, will be longer. So this is the rationale of the table. So I will bring this measure on the femur, and I will insert the K-wire at that level. That KY will be my guide, not only for the length of the osteotomy, but also for the jiggly saw. The jiggly saw was used in clinical patients as well, not only, but of course, I had a hard work beforehand on cadavers to check the technique, because as I mentioned before, I made a lot of mistakes and unsuccessful attempts before finding what now I think is the most predictable way to perform this osteotomy on the desired plane, okay? Without the risk, there is not a technical issue to perform the osteotomy with the oscillating. So the risk is if I make a mistake of evaluation and I take an angle that will exit too medial on the caudal side of the femur, this means that I could leave a very thin, a very weak medial cortex of the femur. This is the point, okay? So for this reason, I hope that I answer your question. Okay, so no other questions. So I hope to I was able to give you some input to think about, some food for thoughts. I hope to meet some of you during some courses, because I think that the course gives us, of course, more time, the option to work on models, to feel the practical part of all the procedures. So it's this for sure. This is very easy comment, let's say, okay? So I thank you very much. I thank you very much for your attendance and your participation. If you have doubts, you can email me, so no problem for that. And I hope we will meet in some place before or later. Okay? Thanks a lot. Bye, guys. Take care.